and good evening, everyone. And it's good to be back with Dr. Diana, as you can see. So welcome everyone to our webinar tonight. And also Dr. Diana Obidniak is with us as well. And I'm very, very excited to have you back as our presenter, as always. And how are you feeling tonight?
I'm feeling great. Thank you so much for invitation. You know, I'm always glad to join your incentive, and I always support IVF Answers team. And I'm so glad to see so many patients today. Hi to everyone. Are you ready to listen our very interesting topic? Please test on our forum if you don't hear me properly, because I'm afraid that today we can have a breaking connection.
All right. Please let us know. Okay, right now I can hear you very clearly, so I hope it stays this way. And I just want to mention that I don't know if you know, but actually, Dr. Diana, it's like 1 p.m., 1 a.m. for her right now, so it's very, very late. So already I would like to thank you for being with us. I know it's been a tough day for you, and I'm more than happy that you are still able to be with us and present this very important and difficult topic as well tonight. And as you know, all the Strong Get Together events have been brought to you also thanks to our ambassadors and partners. So as always, I want to thank them for their constant support. And of course, as you know, Dr. Diana has been with us previously. She had some webinars before, and it's lovely to cooperate with you as well. And as you can see today, she has brought the topic on how to manage successful embryo transfer after recurrent implantation failure. And for those who might not know Dr. Diana yet, she is actually the head of Art of Birth Clinic, which is a brand new clinic, and it's located in St. Petersburg, Russia. And also, I just want to mention that Dr. Diana is the national representative of ESHRE community as of now as well. So we are even more excited, and to have you as our presenter. And well, definitely, it's been a busy time for you, right, Dr. Diana?
Thank you so much. Thank you so much for such a kind presentation. Well, if you don't mind, we will start, because I'm really excited about this topic, about how to manage successful embryo transfer after recurrent implantation failure. Karen has told you that today was a very exciting day for me, and I would like to share with you some joy in my life. Maybe somebody of us know me, and I was for a long time the head of international department of the oldest fertility clinic of Russia. And now I'm so proud to share with you my joy that we have established the new clinic specialized for international patients. This clinic is called Art of Birth Clinic. This clinic was born from my international department of our PT clinic. Many of you may know and have maybe heard the name our PT clinic, because we have made really a lot to make a reliable reputation, because our team is very responsible. And after years of fruitful work with our international patients, we really think that we do relate, and we have deep understanding of concerns and reflections of our patients. So for me, I will just take a couple of minutes before we make a deep dive in our topic, but I would like to share with you, because for me it's really like a baby, because now we can open our doors. It's a new location. You can see at the picture, this is the building, which is considered and which was awarded with the best as the most beautiful city in St. Petersburg. So we have new location, new brand called Art of Birth Clinic. But really, all team. So we have this approved, very famous team of fertility specialists, genetics, embryologists, and managers. You can see the pictures, because I would also tell you that it's not only the main scientific private center in Russia, because it will be associated with three main universities in Russia. For me, it's the main aim of my deal, because I believe that theory and practice should be just associated and should go hand on hand, because in our life, in our practice in this delicate area, we should make a connection between the update in theory and very edge of hand practice. For me, infertility patients, it's just not, we do not consider these patients as sick persons. We really think that it's just persons facing a bit of problems. That's why we've created this clinic, and we created such a design to make an atmosphere of cozy home. Because to say the truth, our team spends so much time caring about you, creating for you embryos, that for me it's really a home, because I spend really so much time there. And I would like my patients to feel also such comfort and calmness when being in this place. This clinic is considered to be the expert center for so-called tough cases. Many of you know that I am the fertility specialist who is well known for collaboration and for fixing the problem of recurrent implantation failure. And by this time, we have a good reputation, because we have patent for algorithm in management of recurrent implantation failure. We also have very approved and feasible guidelines for severe endometriosis and for poor ovarian reserve. We also have our own genetic lab net. It's like a genetic laboratory net in Russia, in different cities of Russia. By this time, it's the largest genetic lab in Russia, called Medical Genomics. So it's a part of our clinic. And we are the only clinic in Russia which has approved guarantee packages by our government. What does it mean? I would like to share with you our experience. I call it 8 years dive into recurrent implantation failure, because precisely 8 years ago, in 2012, I started my fundamental study on recurrent implantation failure. By this time, I started my PhD work, and I faced so many patients with ineffective IVF attempts in their life that I was so shocked, and it was psychologically a very tough time for me also. And I determined to dedicate all my time, my energy, my inspiration to create a proved practical guideline. Because at that time, there was nothing evident, there was nothing certain, it was made by intuition, and nobody could make just good advice how to manage with such person. 8 years after, I have a great team. I'm really proud of them. And my team has gained 4 international awards from American Society for Reproductive Medicine, 2 patents for invention, and viable protocol precisely on this topic. That's why we are bold to provide pregnancy guarantee packages for all our patients. And this practice was approved by external governmental audit. So what is our secret? For sure, I believe that each couple, each intended parent is just an individual case. And for sure, we deep into this journey with you individually. But telling the truth, for sure, we have many things to take into account. But each intended parent is a book, and I believe that we go throughout the treatment just chapter by chapter. I really force my team to not go to the next part without making previous one done. This is our secret. For sure, there is no one standardized protocol for everybody, but our tactic is always very resistant. We always stable till we get the result on each stage. We have the great aim. We have to go with you till you get healthy baby. For us, this is the aim to make you happy to have healthy baby. But usually this great aim should be divided into small tasks. Like book is consisting from different chapters. So our aim is one embryo transfer, one healthy baby. How it works? Let us go through this process like reading the book. So we have introduction. The very beginning of the pregnancy is implantation. And I always tell to my students the story that we should understand the process before we try to diagnose it and try to give recommendations. So implantation traditionally was the process of delicate interaction between the embryo and endometrium. Then there was just in 2012, there was a great opening, a great study that discovered that there are cumulo cells, microenvironment, and various growth factors play an important role contributing or hindering successful nidation. For sure, we always discussing and making joke with my teammates, like they're telling that we are telling you a love story. If we talk about book, that this should be considered as a love story. But telling the truth, I believe that we are talking about detective story, because for me, the main thing that we should find who is guilty, who is the main player, who is guilty in our problems. So talking about brief, for sure, we have many aspects. But if we're talking about main players and main roles, we should talk about embryo, endometrium, and concomitant pathology. So chapter 1 is the embryo. If we talk about the difference of human beings and other biological beings, we should know that there is a prevalence of aneuploidy and morphological evaluation. Talking about prevalence of aneuploid, so abnormal embryos, we should know and take into the account that there is a high percentage of abnormal embryos in human beings. So even when we talk about external morphological evaluation of embryos, and I bet you know that there are also a classification of Gardner telling containing from figures and letters, for example, 4AA, 5AA, 5AA, 2BA. We are talking about classification of embryos. It was actual before widespreading of preimplantation genetic testing. Because by this time we understand that even among high quality embryos, just a half of them will be normal. Usually we have about normal embryos just in 30% or 45%. Thus, we have to take into the account that even in egg donation program, when we guarantee the quality of egg, the male factor will have great impact. So I just want to share with you that there was in 2019, there was a great investigation consider major factors involving in implantation rate of PT euploid embryos. I wanted to say that even in egg donation program, we should implement pre-implantation genetic testing, because for sure in egg donation program, trust me, we have a lot of embryos, always. If the egg donor goes through the attentive investigation as it should be, so I really don't want even to discuss cases when clinics are not reliable and do not provide these guarantees. But when we talk about appropriate practice, good clinical practice, we are talking about great quality of egg donor. But even under these circumstances, we still have from 30 to 45% of abnormal embryos. So I want to pay your attention to this, because several years ago, maybe 8 years ago, my words would sound like a joke, because 8 years ago at the congresses in the United States, in Europe, we were discussing like you should try pre-implantation genetic testing in egg donation program, and everybody were laughing, because we really thought that egg donation program doesn't need, because of a high pregnancy rate and high quality of eggs, we shouldn't consider this pre-implantation genetic testing. But time goes, and now we understand that pre-implantation genetic testing is a new normal and is a must in recurrent implantation field, even when we have to go through egg donation program. Also, I would like to share with you evidence-based data about evaluation of impact of sperm morphology also in egg donation program. Because if you see that we always worry about specific abnormalities, precisely trisomy and monosomy. And when we talk about severe male factor, we always should be aware of possible impact of this male factor. So this result of this trial suggested that diminished sperm quality is correlated to the aneuploidy rate in pre-implantation embryos. Embryo, in terms of good clinical practice, is selection, and selection one more time. So in our clinic, we have just the most modern equipment and the most modern embryo lab which can be. We have ESHRE Witness, it's the modern system of control of embryologists also, and we have Embryoscope, is a time-lapse cultivation of embryo. It allows us not to disturb the embryos during the whole process of cultivation. It provides us a very delicate observation, and we do not provide any risk for the growth of the embryos. Besides, there is a camera inside this box with the embryos, and we provide recording of all the way along of the process of embryo cultivation. Also, we have implemented pre-implantation genetic testing of embryos in most cases, as we have specific patients with multiple unaffected attempts in their medical history, or with specific genetic abnormalities. We have really high percent of pre-implantation genetic testing in clinic. So it's very close to 90%. But it's associated that we have very selective patients. We are famous in Russia to work with the most difficult patients. So also, we're proud that we have implemented artificial intellect in our routine practice. So we collect the Embryoscope big data and provide the specific algorithm to select the perfect embryo for transfer. That's why Making all these selective issues, we provide indeed selective transfer of one embryo in the uterus. Chapter 2. The endometrium. Many years ago, maybe 15 years ago, or yeah, I think close to 15 years ago, endometrium was considered like just an passive partner, because endometrium was considered like second violin, which never plays a crucial role. And if there are any problem with endometrium, it doesn't make sense to pay much attention to this. But throughout our investigation, we have made great understanding and great really we open new era, because nowadays for everybody is evident that endometrium is a microenvironment which plays a crucial role, because it is considered to be a bias sensor of embryo's quality. What does it mean? There is a very fragile balance between the ability of endometrium to accept the embryo. This ability is called receptivity. So endometrium is receptive for implantation. Another side is ability to select the good embryo and to hit the risk of implantation of bad embryo. So when the endometrium is uncompromised, this is the good balance of receptivity and selectivity. Those women will have very, very low risk to have pregnancy loss because of the bad embryo. If we have very high selectivity, women will have no or very, very poor chances to accept a good embryo. So when we talk about infertility, we have very low receptivity and high selectivity. In contrast, when we have another pathology called repeated pregnancy loss, we are talking about enhanced receptivity, elevated receptivity, but unfortunately very low selectivity. This balance can be altered by some problems with functions or morphology of endometrium. So that's why we should consider what morphological alterations, because they are more severe and they are more significant. And also we have to take into the account more rare diseases, more rare conditions called functional alterations. To say the truth, the most common problems associated with endometrium all over the world are inflammatory processes. It turned out that there is a process called chronic endometritis, which is considered to be very a disease with very hidden manifestations. In most cases, you can notice some changes in your menstrual bleeding, for example, like brownish bleeding at the end of your menstrual period, or maybe in the beginning of your menstrual period. You also can see that the bleeding is a bit longer than usually, for example, from 5 to 7 days, so it's more than it should be. But to say the truth, there is no trigger for women to go with these complaints and visit the doctor, because usually the first thing which is significant is the problems with conception. That's why chronic endometritis is so difficult for diagnosis. There are also other problems with endometrium, like hyperplastic process, for example, polyps, and intrauterine synechia. But they are rather easy for diagnosis, and the tactics in all the countries all over the world are very, very similar in contrast to chronic endometritis. Chronic endometritis is a condition involving the breakdown of peaceful coexistence between microorganisms and the host immune system in the endometrium, resulting a special type of chronic inflammation in the endometrium characterized by non-apparent clinical signs. I would like to share with you literature data about the prevalence of chronic endometritis. No doubt it's very significant, but if you look at the slide, you will notice that there is very, very different data about prevalence of the disease. But I would like to pay your attention that the data and the result of investigation is very dependent on the study group, because we should understand that the focus group will determine the result of the prevalence. For example, if we talk about general population, for sure we expect not so high, the prevalence will not be that high, just about 10%. If we talk about unexplained infertility, it will be much higher. It will be about 28%. When we talk about already poor patients with unbenign prognosis, precisely several ineffective IVF attempts or recurrent implantation failure, the prevalence will be close to 45 and 5%. And the patients who are considered to be the focus group for this disease is the patients with recurrent pregnancy loss, because the pregnancy loss itself is considered to be the trigger which provides the chronic formation of chronic endometritis. Talking about functional alterations, we should talk about compromised window implantation. Also, I think not so many years ago, not more than 8 years ago, there were very active investigation of implantation window. What does it mean? We call implantation window the stage of your menstrual period, your menstrual cycle, when there is a synchronization of the processes of embryo development and the maximum of endometrial receptivity. So these two processes should match at the one time. Unfortunately, as we know by this time, only 65% of women who have some problems with conceptions have normal implantation window, and 35% have some distraction of it. Usually, more often we observe that this implantation window is delayed. But by this time we have two approved methods to provide so-called investigation of implantation window and then to perform personalized embryo transfer. These tests are called ESHRE test and Be Ready test. In our clinic, we can perform both of them, but there is no basis to provide both of them for one patient. But they have very good correlation between each other. So it's just the guarantee, because sometimes if the lab has some problems inside, we'll use just another opportunity to make an investigation without no interruption. I would like to pay your attention to the data provided by the author, a good friend of mine, Carlos Simon. He is the head of a genomics company in Spain. So I'm very proud of the result of his team, because for me it's one of the best inventions in our area, called personalized embryo transfer. If you pay attention, we should consider three study groups. One of them was frozen embryo transfer. The second one is fresh embryo transfer. And the third one is personalized embryo transfer. So the third one is the group we are talking about. So it's after investigation of implantation window. And if you pay attention to the clinical pregnancy rate per one embryo transfer, you will see that in group of personalized embryo transfer is just wonderfully high. It's 80 and 85.7%. It's extremely high. For sure, and everything not that good. For sure, even inside this group, we have about from 8 to 12% of miscarriage, but still we have a very high first percentage of clinical pregnancy. And unfortunately, by this time, we have no ability to just exclude and prevent miscarriage at all. But we can use a pre-implantation genetic testing of embryos to minimize the risk of miscarriage. I would like to introduce you the standardized analysis report. So this is the data of patient we have made. Here you can see that there is unfortunately there is no there is a problem with the slide. But here on the standardized report, we see the scale, and according to the scale, we see the result if the endometrium is pre-receptive like this or post-receptive. So when we have such result, we can say that we have information when we know the certain time when we should make embryo transfer. So we have good embryo, we know when to transfer it, and we have to make just a good background for this implantation. So we should talk about concomitant pathology, because I bet patients who had unfortunately recurrent implantation failure had many recommendations to have additional consultations with hematologists, with endocrinologists, with immunologists, and many other specialists. So sometimes less is more, as we say, because it's very easy to make recommendations, to have additional consultations with many specialists. And I understand that all these external consultations, when they are provided with no reliable basis, they can provide only emotional burnout, nothing more. Unfortunately, my patients, after having many consultations, they feel exhausted, but they do not provide it with new results. So I want to prevent you from just unnecessary consultations. You should understand, and I always tell to my student that before making a recommendation, you should ask yourself, what do you expect? What do you want to see from this result, from this lab test, from this consultation? Because you should, from the very beginning of this journey, you should understand and you should hypothesize what do you expect and what should you want to approve and what do you want to exclude when making this diagnostic journey. So I would like to share with you very common things about recurrent implantation failure and concomitant pathology. So usually the first thing the patient with recurrent implantation failure face to is hereditary thrombophilia. So it was also a very interesting evolution of our attitude to hematological problems in our patients. In 2006, there was a clear understanding that two or more thrombophilia factors will affect and provide problems with conception. And maybe you have felt it in your own experience, but after that, after this data, after this study, many fertility specialists and even outpatient OB/GYN specialists determined to administer many consultations with hematologists. But a bit later, just in 2012, we got new information that the one isolated factor has no effect in outcome. Also, a bit later in 2017, we got a very actual information which corresponds to our own experience, to our empiric data, that only factor 5 mutation and MTHFR homozygous mutation will affect conception and will provide problems with fertility, will provide fertility problems, but we can fix it. Also, the factors we always discuss is immunological factors. So, is APS syndrome, antiphospholipid syndrome, a systemic review of 29 studies involving 5,270 patients. So, it's a very great number. According to this data, we know that APS increases threefold the risk of failure of implantation. But I want to, and these are reliable data, but unfortunately I faced that the diagnosis of APS is sometimes verified not according to actual guidelines. You should know that according to evidence-based medicine, there are strict indications, strict criteria when we prescribe and administer lab tests for APS, and also even if there are some abnormalities in lab tests, we should make control test not earlier than after 2 weeks after the first investigation. I want to prevent you from not reliable diagnosis, because for sure APS, verified APS, has a great impact on our tactics, and it's very significant, and we should take into the account not only for clinical pregnancy rate, but for good progression of the pregnancy. But I know that sometimes APS is verified not correctly. The other thing, and we have great experience working with patients with celiac disease, and this is a point we should take into the account. Unfortunately, not many physicians know about this association, but we know that there is a strong correlation between celiac diseases. And I even mentioned that there is an unverified celiac disease, because from country to country, the prevalence of celiac disease differ and is not associated with some ethnic differences, but with the guidelines of diagnosis of this disease. And the third line is autoimmune thyroiditis, so uncompensated problems with thyroid. No doubt there is a triangle including thyroid, ovaries, and uterus. So there is a strong association in immunological basis. When we have a problem in thyroid, we expect with a high chance that this woman will have problems also with her uterus or with her ovaries. So we always make screening tests on thyroid before planning the treatment, and also just a couple of days after embryo transfer. Also, the third line is factors associated with gametes and embryos. I always insist on trying, even when we have poor chance, by trying with the own eggs of women, trying with the own spermatozoa of men, and trying to make embryo transfer to uterus and to try to make a chance with for childbearing for women. But sometimes we have very severe problems, and for sure, all these points are significant. We always take into the account the competence of the oocyte, the functional capability of cumulus cells, and the effect of the ovarian stimulation protocol. By this time, we know about 19 types of ovarian stimulation protocols, so we really think that in most cases, in close to all cases, never mind not depending to the age of woman, we will obtain oocytes. But sometimes from these oocytes we cannot obtain euploid embryos. And if we cannot obtain normal embryos, we cannot think about normal pregnancy. And for women, just trust me, ineffective attempt is not the worst thing. Much worse is to suffer from pregnancy loss or have dramatic experience to have the pregnancy with unhealthy baby. That's why having deep understanding of this situation, I really try to provide the full information about possible risks and when it's possible to prevent this risk. Just making pre-implantation genetic testing is very easy and effective. That's why I really think it's a good thing. But unfortunately, there are some problems by this time which can provide hidden risk. For example, DNA fragmentation in men can provide pregnancy loss, even when we have normal good embryo. That's why in this situation, we have at first we should approve this. The thing. So we should make tests on DNA fragmentation, and after that, we can use some medications to minimize oxidative stress, because oxidative stress provides and results in DNA fragmentation. When we decrease DNA fragmentation till normal ranges, we always see better results. And as we have already told, genetic disorders of the embryo for sure is the main reason of ineffective attempt. But nowadays, in new reality, it's just the thing we really can go through, because we can make pre-implantation genetic testing, and for sure we cannot fix the genetic disorder by this time, unfortunately. But we can select the best one and prevent and just defend our women, our patients, from this dramatic experience. Conclusion of our book. Our IVF success is not just a good embryo or positive pregnancy test. For me and for my team, it's when you take your healthy baby home. To say the truth, you know that embryological lab is highly standardized, and all my members of my team has a lot of KPI which should be controlled to provide perfect performance of each stage of our process. But nowadays we have many sub KPIs, but just one significant KPI is take healthy baby home, because all our types of activity is just useless if we don't have result. That's why for us the main KPI, the main result we make measurements is take healthy baby home rate. Afterwards, I would like to share with you case report. I think that I've never told about this case during my lectures, but it's one of those cases, you know, when patient become more than a patient. You know that I'm just I always make very close relationships with my patient, but this time it was so specific medical history that for me it was like a challenge. When she came to me, she was just 41 years old. To say the truth, compared to my usual age of my patient, it wasn't too high. It was just, I was considering her like a young woman. But she gave me her medical history and I was shocked. She had 27 embryo transfers. You know, I usually make descriptions how many of them were fresh ones, how many of them were frozen ones. But under those circumstances, it was a lot of details, just too many details. According to all the existing guidelines of any country, there is only one recommendation in this situation to make surrogacy program, maybe even with egg donation. But uh, I understood that there is something more because this person seemed fertile. She had rather good hormonal levels according to her age. She had magnificent pattern of her ovaries. There was not severe problems with the sperm, and the only thing it was severe endometriosis. But to say the truth, I just wasn't ready to quit and to think that endometriosis made such a great disease that she had no chance to get pregnant. So we determined she wasn't ready to go into surrogacy program. And to say the truth, I had to, according to legal issues, I have to even take informed consent from her that she rejected from surrogacy program. But I was really excited and I was ready to make my best for her. So we used her own egg programs. We had a new stimulation protocol for her. She never used such medications. For sure, we provided pre-implantation genetic testing for all the embryos we had. After we had approval that we had normal embryos, a boy and a girl, we started to make deep investigation of her uterus. So we performed hysteroscopy. We detected a lot of micropolyps, and you know, sometimes micropolyps, they are not evident according to ultrasound. That's why we need to make golden standard of uterus diagnosis is hysteroscopy. So we deleted these micropolyps. We also made investigation of implantation window, and then we performed delayed frozen thaw embryo transfer in natural cycle, given the result of implantation window investigation. And we also added PRP therapy just because of the autoimmune component of chronic endometritis. As a result, we had clinical pregnancy, delivery with healthy boy in 2018. And the only reason I'm sharing with you this miracle because I want you to explain, it was the first time when she had positive HCG test in her life. When she got this result, she called me and she has very big problems with her psychological status because she has so many ineffective attempts that she just carried on fighting, but she wasn't ready that she will have positive result just somehow, and she wasn't ready. She just asked me one question: what should I do now? Because she really wasn't ready for this pregnancy. But we have good psychological support. We were just in touch during the whole period of pregnancy, and we had healthy boy. And this time, during this pandemic situation, we have performed her 29th embryo transfer, and now she is pregnant with a girl. This is her ultrasound. She allowed me to share with you her history, because I think that this is one of the most inspiring histories and in mine experience. So trust me, everything is possible in this life. We should fight and we should trust in good result. Take care of yourselves. I love this incentive of IVF answers. Together, we are stronger. If you have any questions, please don't hesitate to ask me. I'm ready to answer.
And brilliant. Thank you so much, Dr. Diana. It's always great to have you as our presenter, as I've mentioned, and it was a brilliant presentation with lots of details. So huge thanks already for this. And as you can see, there are plenty of questions ready. So of course, let's get to them. Okay, we definitely can go ahead with the very first one right here. Do you offer your guarantee packages only with your donors or with intended parents that pass the screening? If so, what are those parameters? Do you offer surrogates and guarantee live birth with babies, right? Packages as well, not just pregnancy guarantee, as there could be miscarriages even if there is a pregnancy guarantee. What are these costs?
Well, yes, we by this time, given our possibilities and our equipment, to say the truth, we provide different packages with guarantee for all the patients. For sure, depending on your status, because at first we should take into the account your data, and if there is and after this, we will provide you the personal types of treatment, and all of them are with guarantee. So, what I mean, we always are very friendly and sincere with patient. And for sure, if unfortunately the resources of ovaries are exhausted, we never we never tell that we can create the healthy embryos from nothing. But what I guarantee that at first we always struggle to have good embryos from own eggs. So the only limitations is medical issues if there is if there are if there is a chance to have the embryo from with your own eggs. Uh, if we talk about egg donation, there are no limitations. We are talking just about preparation of the uterus. If we talk about surrogacy program, for sure we are talking about live birth guarantee of live birth for sure. And talking about cost, if you don't mind, you can just send me a message, and my manager will provide you the full information. It just there are many packages, and I always insist on making the treatment individualized. So we would provide you the full information. Just provide a bit more information about you. And the manager will provide you the whole information about prices and organization issues.
And wonderful. Thank you so much for the very first question, of course, for answering. Okay, if you could just clarify this one as there is a follow-up. Are donors anonymous?
Well, in Russia, there is anonymous. But in our clinic, most of the donors, because we have great psychological support also, when talking about international patients, they are ready to have a meeting when personally, or nowadays in this lockdown situation, we provide Skype consultation or Zoom meetings. So we provide the pictures of donors with a portfolio, and if an intended parent want to have a meeting personally or like a video consultation, video meet with the donor, for sure we can provide it.
And wonderful. Thank you so much for the clarification to that one. And the next question is, do you believe only antibiotics can cure endometritis in 99% of the cases, or a new biopsy will be important after treatment?
Well, you should uh, generally, yes, we should understand that antibiotics is the first line treatment for endometritis. But endometritis can be caused by infection and, talking briefly, by endometriosis. So also the disease, inflammatory disease, but which is active and which is caused with by non-infectious issues. So the treatment should be pathogenic. So if endometritis is caused by a kind of inflammation, for example, acute inflammation after pregnancy loss or after some surgical interventions, or as a kind of complication of some incident in gynecological life, our first line treatment will be the first line in hysteroscopy with approval and performing the first stage of surgical treatment. And after that, we make a complex therapy, taking into the account the result of histology and immunohistopathologic investigation. And according to this result, because we need morphological evaluation to assess the activity of the process. After that, we provide one of the three algorithms of treating endometritis. In first line is antibiotic, but sometimes we also make injections to prevent formation of adhesions, connections of the tissue of endometrium. But in case endometritis is associated with endometriosis, we should cure and we should treat the main problem. No doubt is endometriosis. So the answer for this question is that treatment should be defined by the cause. At first, we should understand which is the primary cause of this inflammation, and only after that we should make approved pathogenic treatment. Talking about new biopsy will be reported after treatment. It's after ESHRE. Well, Asherman syndrome is not after, is the result of chronic endometritis. So it's the severe, I'm just trying to explain for everybody that this is severe and very tough connections between layers of endometrium. So in this point, Asherman syndrome is one of the severe situations when antibiotics are not useful, because the main thing is that the tissue of endometrium was so compromised that it's poorly regenerated. In such situations, we usually recommend to use means of regenerative medicine, precisely pre-implantative, precisely PRP, platelet-rich plasma therapy. It's safe and it's approved to have good results for regeneration of endometrium. Unfortunately, it doesn't work in 100% cases. So if we talk about very long history of Asherman syndrome, sometimes we talk about several surgical interventions to fix this problem. In these cases, unfortunately, sometimes even therapy doesn't work. There are some investigations, some trials investigating the stem cell therapy, and there are some data about good results, but unfortunately, stem cell therapy by this moment is not approved and is still considered as experiment. But we are waiting for this, and our team is also working on it. But by this time, to say the truth, we usually don't use antibiotics in this situation because it's not an active process. It's not an active inflammation. We're talking about the complication, the result of this inflammation. So we usually implement regenerative medicine, but unfortunately, in the toughest cases, we have to talk about surrogacy program. I hope my answer was full. But if you have more details, if you need more details, please tell me.
Thank you so much. And as you can see,
Okay.
there is a thanks from Marcia as well. Thank you so much. And let's have a look, okay? If you could explain also, how can endometriosis be accurately diagnosed?
Well, we have certain guidelines for endometriosis. We should understand that endometriosis is just the name of a very large disease. So it's called endometrial disease because endometriosis can affect the uterus, the uterine tubes, ovaries, and even all the organs, including rectum and your urine bladder. Depending on the localization of endometriosis, we should make the golden standard of diagnosis is laparoscopy or hysteroscopy. The thing is that we can detect the locus of endometriosis just by our eyes when performing endoscopic investigations. So by this time, unfortunately, diagnosis is invasive. But when we talk about endometriosis of uterus, we have rather reliable signs by ultrasound scan, and so we can hypothesize according to the clinical signs, according to the ultrasound scan data. We can hypothesize that there is endometriosis of uterus, but we should prove it by performing hysteroscopy.
And
Okay.
wonderful. Once again, thank you so much for explaining how it's diagnosed. And of course, there is a next question. And in the meantime, thank you from Victoria for you as well. Let's have a look. Okay. So, what is your
Thank you.
view on surrogate mothers who are carrying embryos that are not at all genetically linked to her, but she has a carrier condition that, if she was a carrier condition, that might cause miscarriages or stillbirth?
Well, if we talk about genetic, for sure, surrogate mother has no genetic association with the embryos. It's just the basis for these so-called gestational surrogate programs. So for sure, surrogate mother uh, should be healthy. So we, no doubt, we have very strict investigation checklist. We investigate not only her gynecological history and her OB-GYN status. We also make a deep investigation of function of your other organs, like lungs, heart, even stomach, because we have to be sure that during this very long period of time, 40 weeks so-called, we measure the pregnancy in 40 weeks, it's a stress for the organism, and we should be sure that the condition of the whole. So in some countries, it's we have to make examination by even general physician, just to make general screening of the whole organism, to be sure that this woman is healthy enough to bring the baby, and there are very poor chances that there will be some problems. For sure, we cannot exclude any risk, because even very young and very healthy woman sometimes has indications for even cesarean section, but we should minimize that. That's why we have very intensive investigation. It's different comparing to egg donor, because the checkpoints are different and the aim of this collaboration is different. But for sure, surrogate mother is under great control. According to our experience, not more than 20% of women who go through this checklist are approved to be the candidates for surrogacy program.
All right, thank you.
Would
And as you can see,
epigenetics
there is
somehow
a follow-up, yeah?
Okay. Would epigenetics somehow come into play, even though the donor and my husband have no career condition in common, even though the surrogate mother has nothing which is the same as no, we, as repeat, as we have no genetic relation, no genetic connection between surrogate mother and baby, there will be no impact from surrogate mother to baby. So don't be afraid of this.
And excellent. Thank you so much for that reassurance, of course, as well. And let's have a look. If you can explain what is a chemical pregnancy.
Yeah, so chemical or biochemical pregnancy, also you can meet the term molar pregnancy, is the sign of an interaction between the embryo and the endometrium, so your uterus. We call biochemical pregnancy or molar pregnancy when we have elevated HCG test, so positive HCG test. You can make it by some urine strips, or you can make it, which is more preferable, when you have blood test on HCG, a human chorionic worm. But so this is the approval of pregnancy. But we can expect that this HCG test and HCG result will be elevated while the pregnancy has a progression. Unfortunately, in some situations, this implantation process is interrupted. Right? It can be interrupted by several factors. We have discussed it already during this session. It can be provided by genetic status when the embryo is not checked, by problems with endometrium, especially when we talk about chronic endometritis, or by thyroid, and many things. The result is that we do not have enough time to approve the pregnancy by ultrasound scan, because we can make ultrasound scan and see the fetus and see the pregnancy in uterus just after a certain period of time. Till this period of time, we can control progression of the pregnancy only by lab test, only making blood test on HCG. And if unfortunately during this period of time, HCG test, HCG result was elevated at first, and then it comes down till zero, we are talking about biochemical pregnancy. So briefly, it's interrupted pregnancy at very, very early stage. We do not consider it as a clinical pregnancy. That's why we consider that there was no pregnancy. Even we had this interaction between embryo and uterus. We are talking about primary infertility because it's more correct. But to say the truth, it's not a bad sign, because if we at first had no result, it was zero HCT, and after that, during the treatment, we reached this biochemical pregnancy. For us, it's a great sign that we are on the correct way to the pregnancy.
And again, thank you so much for that. And of course, there's a thanks for the clarification from the patient. And let's have a look. Of course, more of those questions are coming up. So what is the name of the test that I could ask my doctor to rule out thrombophilia?
Well, if you don't mind, please leave out, because it's not a one test. There are several lab tests, and I need to know your medical history to provide you the list which is necessary for you. If you don't mind, please send the information to Caroline, or maybe you have Caroline can provide you with my email, or on the last slide there was information. You can send me some details from your medical history, and I will provide you the list which is approved precisely for you, because there are many different lab tests, and we need to clarify this according to your medical history.
All right, wonderful. Thank you so much. And of course, I have sent you just the link where you can get in touch with Dr. Diana. And of course, this is her email address, so you can just straight away get in touch with her as well and provide more details. And I'm sure she'll be more than happy to help you out with that. And let's have a look. Okay, next question is also ready. Do you feel a fresh transfer is better than a frozen transfer? I have had 2 fresh transfer failures. I have 3 frozen embryos, but I am concerned that the percentage of success is less with a frozen transfer. Thank you for your advice.
Thank you for a great question. I bet that many of patients have the same concerns, but to say the truth, there is nothing to worry about. Frankly, we expect better outcomes when we talk about frozen embryo transfer. I will explain why. Because when we talk about fresh transfer, to say the truth, it's just like an old school tactic, because if we implement pre-implantation genetic testing, we will have delayed embryo transfer. We just have no ability to make first cycle. If we're talking about severe endometriosis, we also have to make embryo transfer, which is delayed. If we talk about egg donation, like you're telling, usually we also have to talk if there are indication from your husband, from your partner, if there are some problems with sperm, because as I have told, we during recent 3 years we have implemented widely like a must for egg donation programs. We also perform pre-implantation genetic testing, and we have great results, because unfortunately there are also dramatic situations. So the thing is that when we talk about fresh transfer in egg donation program, there is the problem can be from 2 sides, from endometrium, and we should assess the quality of endometrium, the pattern of endometrium, and we should expect the problem from the embryo, because if we talk about fresh transfer, we cannot provide pre-implantation genetic testing. And in my city, I'm also ready to discuss with your personal data. You can provide send by mail the data of the result of sperm analysis, and I will check if there are indications for pre-implantation genetic testing. But generally, if we're talking about effectiveness of fresh versus frozen embryo transfer, there is no difference. And sometimes if we talk about stimulation cycle and frozen thought embryo transfer, in frozen thought embryo transfer, outcomes will be always better than in first cycle. When we talk about egg donation program, it's usually no differences. So I think the problem is certainly not associated with the statute that the embryos were frozen and then defreeze.
And thanks a million for explaining this one, of course, as well. And thank you very much. Thank you so much for your response, of course, from the patient here. Okay, of course, let's have a look. Next question is up. Do you test for the balance of good and bad bacteria within the uterus at your clinic? Do you believe an incorrect balance can affect fertility?
I'm sorry, I didn't see the question on my screen. Can you check?
Yes, okay, just a second. And I believe that Dr. Diana disappeared for a second for us, but don't worry. I see that she is back. We just need a second. Okay, Dr. Diana, you can hear me, right?
Yeah, I
Yes.
can hear you. I'm sorry.
It's all right, of course. You can see the question now, I guess, right?
Yeah.
Perfect.
Do you test the balance of good and bad within the uterus? Do you believe that? Yes. To say the truth, it's I have even maybe we will discuss with Caroline. I have a pretty interesting session and lecture concerning the microbiota. It's called so this issue, the question is about microbiota in uterus. It's very interesting that at 70s of last century till 70s of last century, there was understanding that uterus is sterile, so there are no bacteria inside the uterus. By this time, just 50 years after, we know that there are a lot of bacteria. There are different types of bacteria, defenders, tourists, and we usually give them some funny names. But for sure, we have to. I know that it's rather new information, and not all physicians trust this data, but I was involved in this study, and I know this from different sites. I know that we are talking in most cases about a specific bacteria, which is called bacterial vaginosis. And for sure, we have to exclude this problem because we have a strong correlation between ineffective IVF attempts and this bad balance of microbiota.
This is a follow-up as well.
On bacteria. Well, the thing is that we can't fix it. Sometimes it takes not a very long period of time, but for example, 2 or 3 months, because microbiota has association with the activity of the whole organism. So sometimes we work also with intestine, we work with microbiota in different organs, but it was working on it. We should try to fix it. I cannot provide you the treatment plan because I have no information about what kind of bad bacteria you have. in 90%, but I expect that there are just, so-called conditionally normal bacteria, but in a more quantity than we expect. So also, I'm wide open. If you want, you can send me the information, and I will check if I need some more details. Me or my manager will contact you, but I will try to make prescriptions if it's possible according to this data.
And wonderful. Thank you so much once more for that. And of course, there is a thank you. Much appreciated from the patient. Let's have a look. Okay, next question is up. Do you have experience in treating patients with endometriosis with intralipids to reduce inflammation in general before the transfer? I have one embryo already, and the doctor does not believe in 3 months of Lupron and thinks this is harmful for me, but I have some hope in intralipids. What else would you recommend?
Well, we have we had the practice of intralipids. I want to explain you that there is no intralipids are never considered as the treatment of endometriosis. So I totally agree with your physician. It's not the any line of treatment of endometriosis. Some years ago, intralipids were considered the method of therapy over immunological conditions. But intralipids are very difficult medication, and it should be performed. This injection of intralipid should be performed only in terms of hospital. And to say the truth, last years, its effect was, we understand that it was really overestimated, but we have another tool. It's like protein, and it not protein. It's like human immunoglobulin. So we usually use a human immunoglobulin G, and there are different types depending on the country you're from. But in the situation when you have problems with your immune system and recurrent implantation failure in your medical history, there is a basis for prescription of human IgG. But intralipids are out of the recommendations.
All right. So of course, again, thanks so much for that. Okay, let's have a look at the next one. So, do you think small size, less than 5 centimeters fibroid, can affect implantation?
Well, we talk about small sizes when it's less than 4 centimeters. Fibroids which are more than 4 centimeters are considered to be harmful and are considered to be indication for surgical treatment. So all the fibroids which are more than 4 centimeters are considered to be indication for surgery. Never bind the location and the type of fibroids. The size more than 4 centimeters is not small one. Is the direct indication for surgery.
Wonderful. Thank you so much for that once more. There is a question. Next one will be like 2 parts, and it's a bit of a longer question as well. Okay, so let me just go ahead. I'm 45 and had 9 round own egg, own sperm IVF cycles over the last 7 years with different clinics, all good embryos and only implantation once, which ended in a miscarriage at 10 weeks. We moved to donor egg, own sperm last year from proven 21-year-old donor. This resulted in 6 excellent good quality embryos which we froze. I have had 5 embryos transfer with these and still no positive result. We have one Donor embryo transfer left, grade AB. Should I have any test before we transfer this final embryo? In the past, I already had hysteroscopies, laparoscopy, and ERA test, as well as thrombophilia test and immune test, NK cells, TNA, alphas, etc., with no issues. I should also mention I had PGS testing on one of our own egg, own sperm IVF rounds. The embryo result was normal, but this did still not implant.
Can you tell me? Thank you so much for a question and for um, sharing sharing with me your history. I really appreciate this. I want to tell you that when we talk about your this miscarriage factor at 10 weeks, it's a very significant point for diagnosis because if this pregnancy stopped at 10 weeks stage, it's for us we need to exclude APS syndrome, antiphospholipid syndrome. If the pregnancy stopped earlier, but unfortunately the diagnosis was verified only at 10 weeks, we should think about problems with genetics in the embryo. I didn't, I don't, oh, it stopped at 7 weeks. Could you please also briefly tell me about the quality of the sperm? Because as I understand, when talking about good quality of embryos in egg donation program, there wasn't pre-implantation genetic testing in this egg donation program. Or was it? Could you please tell me if you listen to my response? So, from my point of view, for sure, I need all your all the details from your medical history. But um, talking briefly, I think that it's very likely that there was problems with the embryo, but after this miscarriage at 10 weeks, because you have told me that the embryo stopped at 7 weeks, and unfortunately, during 3 weeks, this embryo with non viable tissue, unfortunately, was in the uterus. Just imagine that during 3 weeks, there was the trigger of inflammation. So usually after this pregnancy loss or interruption of the pregnancy, there is a high chance for chronic endometritis. And in this point, hysteroscopy is just the mode of diagnosis. So for sure, we should find the signs of chronic endometritis, but then treat them. Otherwise, for sure, there will be ineffective attempts even when we place into the uterus a haploid approved embryo. Never mind it's with own eggs or egg donation embryo. So what I recommend to, if you haven't made pre-implantation genetic testing of the last egg donation embryo, please make this test, and also please pay more attention with your physician, pay more attention to the endometrium, pay attention to your menstrual period, to the menstrual bleeding, if there are some brownish bleeding, because it's a very significant and very important sign in our clinical practice. Sometimes chronic endometritis is underdiagnosed and undertreated. I hope I helped with my.
Thank you so much for your recommendations, of course, indeed. And I do hope it has been helpful for you. All right, so let's have a look. There are like 4 questions left. We will be slowly finishing. And yeah. Okay, that's good. That's the information I received from the patient. I will email you my whole story, and I think that will be best. That way, I'm sure Dr. Diana will be able to provide you even more details, of course. perfect. Thank you so much. And let's have a look. Okay, next question. Again, I believe sorry, no, next one is right here. I'm awaiting results of PGS for embryos in Ukraine. They guarantee 2 embryos for transfer. Would you recommend only 1 embryo for transfer?
Yes, no doubt. After pre-implantation genetic testing, when we have approval of the embryos, we strongly recommend to make transfer of just 1 embryo. Remember that our aim is to have healthy baby. And when we talk and we have good preparation, and I believe that you have good preparation, and we place 2 embryos after pre-implantation genetic testing, we have extremely high chances to obtain multiple pregnancy, which is associated with elevated risk for both for baby and for mother. So yes, I strongly recommend to make selective embryo transfer.
Wonderful. Again, thank you so much for that. And next question is, our high FSH dose bad for equality? What dose is the maximum that is effective? Could egg resulting from stimulation with too high FSH produce embryos with abnormal chromosome?
Well, thank you for the question. As I understand, you mean high FSH dose during the stimulation. Um, so for sure, there are limitations, and generally, we are talking that we shouldn't use more than 450 international units in daily form. But it's a large dose. If we use more than this dosage, for sure, we expect that sometimes we obtain worse air quality. But to say the truth, we don't. We understand that we use high doses when there are problems. Usually, we talk about patients of advanced age. We talk about patients with obesity, so with severe risk factors for air quality. That's why we don't have uh, evidence that high doses, more than even 450, will make bad impact on air quality. It's more likely that the reasons why we have to administer high doses of stimulation will result in bad quality of eggs. But generally, we never make administration of more than 450 international units during one day.
Thank you once again for the explanation. And of course, you can see the thanks from the patient. Okay, let's have a look. Of course, as I mentioned, there are a few questions left. So, are there any major genetic screening diseases that intended parents should consider avoiding when considering surrogates?
Well, you should understand that talking about surrogate mothers, according to all the guidelines, even karyotype is not obligatory for screening, because as we have told, there is no genetic connection between surrogate mother and the embryo. That's why the main aim of screening, and it's really large and multifactorial, screening is not considering genetic issues, because there is no connection, there is no basis for hereditary from surrogate mother to the embryo. And we are not talking epigenetics is the other thing, and epigenetics cannot provide the problems with the embryo. So my explanation for you that as there is no genetic connection between surrogate mother and the embryo, the genetic screening for surrogate candidate is usually not applicable because it doesn't make sense. We make a very deep and very accurate genetic screening for egg donors, but for surrogate mother, it doesn't make sense. I hope
Excellent. Thank you so
answered.
much for that. Sorry about this. Of course, I'm right here. So let's have a look. Okay. Next question is up. There are like two parts of that. I had immune test done. My NK cells and other levels, CD3, NKD, and sorry, not sure. I was on hydrocortisone for over a year and it didn't change very much at all. And what are the chances for a successful ESHRE round with the use of intralipids?
Well, to say the truth, all these features which he provided are not considered as an indication for hydrocortisone, especially for such a long period of time. To say the truth, we do not think that they will provide, they will affect the quality of embryos and especially the rate of fertilization, talking about ICSI. So I think that we should talk, and I would like to see the data about quality of eggs. Could you tell me how old are you? I'm sorry for this question, because sometimes we're not talking about immunological reasons. 37 years old. Yeah, see, thank you. You have already been pregnant, and I think that there can be some problems with equality, for example, endometriosis or 7 years ago. My idea is that I really do not believe that immunological factors are leading to bad egg quality in your situation, even at your age, and we all apparently fine. Hysteroscopy, we're talking about hysteroscopy can provide data about the internal surface of uterus, and endometriosis of ovaries can be detected by laparoscopy. Also, you can at least make a non-invasive test. You can make blood tests on CA125 and send the result to me. But to say the truth, I don't think that intralipid will make any difference for fertilization rate or for blastocyst rate. I think that we should consider and find the real reason of the compromised egg quality, and given this result, administer the therapy as preparation for ICSI and for assisted reproductive technology cycle. But I really don't recommend you to use intralipid. I don't see any basis to improve the outcome because of the intralipid. There is no correlation and association between intralipid and fertilization rate or blastocyst rate.
Perfect. Thank you so much, of course, indeed, as well for answering this. And thank you very much from Carrie for you. And there are like two questions left. We will be finishing after that. And the question is there a possibility of successful pregnancy with severe diffuse adenomyosis with your clinic? Myometrium thickness of around 30 millimeters.
Yes, for sure, we have, but you should understand that the secret of success in endometriosis is the preparation, and sometimes it takes about from 3 to 6 months. For sure, you don't have to be in the clinic during this time, but we are in touch distantly because it's extremely important when treating endometriosis to be patient and to follow recommended time frames for treatment of endometriosis, especially when we talk about severe adenomyosis. So for sure, we have many successful pregnancies, but it always a long period of preparation. Our idea, one embryo transfer, but successful one. That's why when we talk about severe form of endometriosis, given the specific features of treatment of endometriosis, it always take a little bit mm, long period of time. But just you have to be patient and prepare properly, and everything will be good.
Wonderful. Thank you so
So
much once more for that, of course. Okay, and of course, thank you from the patient as well. And it looks like that this will be our final question for tonight, and it is I'm the 41-year-old woman case. It's regarding your presentation as well. Could you clarify once again what did you do against endometritis, sorry, and why did you use PRP in her case?
well, if we talk about endometritis, there are different protocols given their activity and the stage of endometritis. If we find that the main reason which resulted and triggered the formation of endometritis was infectious, so we have the complex therapy with antibiotics. No doubt with specification and determination of specificity and sensitivity for antibiotics. So we identify microbiota in the uterus and make prescribe antibiotics given this result. If we have data that endometritis is associated with autoimmune history, autoimmune system, or with endometriosis, for example, we have to make another approach. When we talk about associated endometritis associated with endometriosis, our primary aim is to treat endometriosis. So we have to administer hormonal treatment for a long period, from 3 to 6 months, without any interruption. Another type of endometritis is so-called long-existing endometritis, when, for example, we see Asherman syndrome. In this situation, we also clarify which stage we observe. If it's just already non-bacterial endometritis, we don't have indications for antibacterial therapy, antibiotics, and we have to just surgically, by surgery, delete these connections, and after that, using regenerative therapy from precisely PRP therapy, we try to mobilize and activate natural resources. In many situations, it works, but unfortunately, if we talk about toughest cases and a during very long period of time existing adhesions, because there are stages of Asherman syndrome. Sometimes, unfortunately, even PRP doesn't work.
Excellent. Once again, thank you so much for that. And okay, if you could just clarify, there's one more thing that has shown up just right here. Sorry, thank you for the presentation. I wanted to know when it is advisable to transfer to embryos.
Well, to say the truth, we just maybe one situation when we can make a transfer of two embryos when we talk about a young woman who is very inclined on bringing two babies, who is mad about having two babies, twins, but because in all other cases, the risks associated with multiple pregnancy are too dangerous comparing to the idea of making transfer of two embryos. To say the truth, in clinics with good embryology and with good equipment, usually there is no basis for transferring two embryos because yes, for sure, the pregnancy rate will be a little bit higher, just not quite twofold elevation, just several 3 or 5%, for example. But the rate of twins is extremely high. That's why we do not recommend to transfer two embryos except very young and very healthy women when we consider that this woman has very low risk and she is she is strong enough to bring multiple pregnancy. So it's not the case when it's advisable. We never advise transfer to embryos. But if we talk about good, appropriate lab practice, because sometimes if a lab practice is not good and the embryos are rather weak, sometimes well, there is nothing to do except transfer to embryos. But if we talk about good clinical practice, good lab practice, there is no indications for transferring to embryos.
And perfect once again. And huge thanks, Dr. Diana. You've been simply brilliant as always. So thank you so much for joining us tonight. I know it is very, very late for you. So I am even more in awe that you are able to be here with us and answering all those questions, not easy ones as well. So I am always very happy to have you here, as you know. And of course, as you can see, there are plenty of thank yous coming up your way from all the patients. So huge thanks for answering all their questions. And it's so great to have you and great presentation once again. Thank you for your eloquent and detailed answers. Of course, couldn't agree more, really. And before I let you go, anything you would like to add?
Thank you so much. It was a great pleasure for me. And I know I'm so glad to see, I know already some names of the patients. I'm really so glad to see her. I really appreciate your trust. And I hope that all of you will get the pregnancy very, very soon. I hope you and I wish each of you will reach the positive result as soon as possible.
Thank you so much, of course.
Thank
And fingers crossed to all of you. And thank you, everyone, for your kind words. We are definitely happy that it's been useful for you. And no doubt, of course, remember, you can always get in touch with Dr. Diana, and I'm sure she'll be more than happy to help you out and assist you in any way. And of course, remember, it has been recorded. You will have a chance to watch this again. And of course, if you go to the link I have sent to you, there is an option for you to watch previous webinars with Dr. Diana, if you would like to do that, go ahead and do it. And of course, this webinar will be uploaded on our YouTube channel tomorrow at my IVF Answers. And of course, there are plenty more of those events coming up. Dr. Diana, thank you so much from whole team, IVF Media team. We are very, very, very happy and excited that you are back with us. As always, it's a huge pleasure. Thank you so much for your time. I know it's definitely late, so have a wonderful and restful night. Everyone else, wherever you are, have a lovely evening, have a lovely day. And thank you so much for joining, for your questions. It's great to have you here with us as well. Thank you so much. Take care. Dr. Diana, till
Yeah.
our next event.
Yeah. Thank you.
Thank you. Bye.